Greetings from Biochemistry and Immunology Department of Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai. I thank for this International Laboratory Medicine Case Contest. Special thanks to IFCC, IAC, PALM, and Turkish Biochemical Society, and CAHU, and MINDRE for giving us the opportunity to share our case and share our project. So today I'll discuss this project with you, acute kidney injury and developing the electronic patient record, or ELR. And the study is done by Ujja Parekh, Poonam Mandavkar, Umesh Mariani, and me. And let's hear from patients.
So good afternoon. My name is Deepika. I'm daughter of Mr. Ramesh Khanna, age 79. And we came here almost 25 days back. And 26th day before, I stay in Dalhousie in Himachal Pradesh. So 26th day before, I was having a conversation with my pop, and he said that you walk very less, and I walk almost 7 kilometers a day. And on the 25th day, I got a call from my caretaker that something is wrong and he's not well. There's a lot of fever. I rushed down from Dalhousie to Mumbai, and we brought him to Kokilaben. And here he was diagnosed of acute kidney injury because of an abscess in the liver. Now, he has always been a very, very fit person, and he's been really taking good care of his health, drinking a lot of water, hydrating himself. So I never thought that this can ever happen to him. Now, what I was told was that, since there's an e-alert system and they kept on monitoring his keratin, as a result of this, they controlled it in time and they did not let this acute injury turn out to be a chronic one. Had it been a chronic one, then recovery would have been very, very difficult, very painful and time consuming. So I'm really thankful to the team of Kokilaben for diagnosing it with their e-alert system. And
so this is our best recognitions. If any of our project as a lab physician or diagnostician, if can affect in patient's life and if can ease clinicians' diagnosis and treatment, so that's the best recognition for any lab physician or diagnostician. So acute kidney injury is abrupt decrease of kidney function resulting in accumulation of metabolic waste product as well as dysregulation of volume status, electrolyte and acid-base balance. And the condition is very common. Around 5% to 20% of all hospitalized patients we see acute kidney injury, and the independent risk of mortality as high as 20%. So, and also it leads to end-stage renal disease, and then dialysis, chronic kidney disease. And if you see 13.3 million cases every year and globally, and 1.7 million deaths. If you see the low and middle income countries and developing countries, around 11.3 million cases per year and 1.4 million deaths. So because of that, electronic health record or electronic record plays very significant role for case diagnosis and also prognosis of the case. If you see this study, they say that mortality reduction is 0.8%, length of stay 0.3 days reduction, and dialysis use 2.7% reductions. So based on KDIGO AKI detection criteria, if we raise the ELR, so this is real-time AKI intervention can be developed, and AKI definition is, all of us know, serum creatinine more than 0.3 milligram per deciliter within 48 hours, or more than equal to 1.5 time rise in serum creatinine in last 7 days, and urinary volume less than 0.5 ml per kg per hour for 6 hours. And these are the different stages, stage 1, 2, 3, based on the serum creatinine and urinary output. So this is our study. We have taken a pilot study for 20 days and inclusion criteria, all patients of 18 years of age or older, and exclusion criteria where on admissions, if value is more than or equal to 4 milligram per deciliter, or the history of chronic kidney disease or end-stage renal disease. So we have taken the KDIGO or creatinine criteria as for our alert, and this displayed in our clinicians' display board that most recent value of creatinine, lowest in last 7 days, highest in last 7 days, and lowest in last 48 hours and highest in 48 hours. And they can agree and disagree with our e-alert or electronic alert of acute kidney injury. And this is our critical call report, how we informed our clinicians or ward or IPD about the acute kidney injury alert. And this is the critical call log, and these are the different variables we have taken care when we have did this project. And this is the flow chart where in 48 hours we see if there is more than equal to 0.3 milligram raise, or in 7-day period if it is more than equal to 1.5 time rise in creatinine. And we do different staging of AKI alert based on this flow chart, stage 1, stage 2, stage 3. So this, we have taken total patients around 4,708 patients, and included patients were 4,439, and AKI e-alerts were raised in 273 patients, and in them true AKI e-alerts were 239 and false AKI e-alerts were 34. And if this is the graphical representation of the same, and this is the AKI box plot and non-AKI, and stage-wise AKI patient, like stage 1 is 202, and stage 2 is 18, and stage 3 is 19 patients. And these are the box plot of range of creatinine in different stages of AKI patients. And now we have done the clinical validations. In that, we have screened all the 200 case sheets, and we have seen in inclusion, we have done around 1,799. In them, AKI e-alerts were raised in 143 cases, and number of patients with documented AKI diagnosis by clinicians, when we have checked the record in the clinician's file, in the patient's file, only 46 cases were detected. So if you see in rest of the cases were not detected if we have not raised AKI e-alert. So because of that, the significance of this AKI alert, and otherwise 214 true positive alerts was raised in 2733 alerted patients. And if you see the primary departments, who are the stakeholders, you will see it is not only nephrology, it's from critical care, oncology, cardiac care, and pulmonology. All the departments are involved in this AKI e-alert, where in those departments AKI e-alerts were raised in their referred patients. So the advantages is we get the data, we put the algorithm, and we develop the e-alert, and we apply the rule based on the subject matter experts by the nephrologists. They do the clinical validation, and it delivers high quality care with patient-centric insights. It reduces variability and improve workflow and efficiency. So actually it improves revenue, improve quality, improve patient satisfaction. And we have seen during the COVID time, is because AKI patients are very common in COVID complications. So we have seen many patients were detected based on AKI e-alert. And this is my painting to dedicate all the diagnosticians who helped to heal. So if you see, the clinicians are treating patients, but if you see, we are doing the test in autoanalyzers. So this healing hand is ours. So we help the clinician to heal. So I acknowledge all the healers present here. Thank you.